There are two forms of kidney problems. We have acute and chronic. For acute part, the new name is acute kidney injury. Used to be called acute renal failure. No, not anymore. AKI is a rapid loss of kidney function. Rapid as in within a few hours. So this can develop from a number of causes. We'll look at three categories that can lead to AKI. Meaning AKI is more common than you think. Patient may come in with one problem, but they have AKI at the same time. All right. For example, burn patients are in AKI. Heart failure patients are also in AKI when they come in. Patients who have sepsis, sepsis, infection, meaning it could be from COVID, from pneumonia, from whatever, a UTI, for instance. Okay. So they come in with sepsis. All sepsis patients suffer AKI. All right. So this is the only time we'll discuss AKI because AKI will be part and parcel of more disorders that we will cover not only this semester, but the next. Next semester, we will cover more critical care problems, but all of them will have AKI. Are we clear? So again, AKI is more common than you think. It may not be the principal problem, meaning something else happened and then they develop AKI. Okay, I'll show you a table shortly. So yes, we are on 1564, page 1564, chapter 48. All right. So that's the general description of AKI, meaning there's acute rapid loss of renal function. The kidney shuts down. It stops working in a few hours. Okay, that's why it's called acute. The good thing about AKI is the patients can recover, meaning they can recover kidney function if diagnosed and treated right away. Again, they can recover if diagnosed and treated right away. Let's review the functions of the kidneys. Give me 4 kidney functions. What do they do? Regulate fluids and electrolytes, correct? That's the major function of the kidneys. Because they regulate fluids, therefore, can they regulate blood pressure? That's the second. The third would be, can they help with elimination of waste products? Yes, they eliminate drugs, they eliminate everything, waste products, name it. Whatever waste products we have, kidneys will take care of it. Okay, so that's another function. Fourth function is they secrete erythropoietin. That hormone assists with red blood cell production, right? There are other kidney functions, but let's stick with these 4. So what happens to these 4 functions when the patient goes into acute kidney injury? Are they still functioning? Are these functions still present? No. So what happens to the ability of the body to eliminate waste? What happens to its ability to regulate fluid and electrolytes? What about waste products? However, with the erythropoietin hormone, it doesn't really affect AKI. It's not manifested because this is so fast. It occurs so fast, we really have no time for anemia to happen. Does that make sense? Because this happens in a matter of hours. The patient will die after 24 hours if not treated. Okay, so AKI is acute, so acute that the patient will not make it after 24 hours. Are we clear? All right. So therefore, is there time for anemia to develop? No. Okay, so there will be, you won't see that, the patient won't live to see that occur. Okay, there are classifications. The 5-point system is called RIFLE, and it's on table 48-2. It's a boring table, just tells you how severe the AKI is. We have RIFLE. They're all based on two things, GFR and urinary output. Remember I said earlier, urinary output minimum is 30 ml per hour or with 0.5 ml per kilogram per hour. Okay, so here's the basis for that. So critical care patients such as AKI patients, we no longer look at 30 ml per hour because really on a critical patient, is that really accurate, 30 ml per hour? Don't tell me, let's say I weigh 163 pounds. Don't tell me that a 600-pound patient will still have 30 ml per hour like me. Let's say it's who's 300 pounds? Shaquille O'Neal, right? What is he? 7'1" and over 300 pounds. So don't tell me our kidney function, kidney size is the same. Are we? Of course not, right? So therefore, do I expect him, if he's in critical condition, to have the same urine output as me? No. Okay, so therefore it's based on patient's weight. So 0.5 ml per kilogram per hour is the more accurate measure for critical patients. All right. So don't worry on the table 48-2. This is just for you to appreciate the severity, all right, for each classification. Are we clear? I won't test this. All right. All right, let's go back here on categories. So categories are very testable because you need to know what category your AKI patient is in. Therefore, you know and can help the physician with the treatment. Okay, there are three categories. No, sorry. It's on a different table or chart. I'll get to that when we find it. There are also three phases in AKI. So let's discuss the phases. Let's forget about the initial phase because most textbooks don't really talk about the initial phase. So let's cut it down to three. Okay, instead of four, we'll forget about the initiation. Let's start with the oliguric phase. What does oliguria mean again from last week? A urine output of less than 400 in 24 hours. So right here, 400 in 24 hours. So that means if we are supposed to make 1500 mLs per day, what happened to the other 1100? It's somewhere in the body. Okay, so we don't know where exactly it is, but we know it did not come out as urine when it was supposed to come out as urine. It did not. So therefore, what is the patient's fluid balance in the oliguric phase? They are in fluid volume excess. Okay. However, don't rush into the interventions yet because it really depends on the category. Okay, because we have three categories of AKI. We just know that during the oliguric period, patient is not making enough urine, correct? That's why we call it oliguric. Now, if they survive this period, meaning they can only progress to the next phase if they receive treatment. If these patients are not diagnosed, or let's say we never got them to the hospital during the oliguric period, they won't make it anywhere. They'll die in the oliguric phase. Again, I repeat, the phases the patient will only progress through the phases if they receive treatment. Meaning, if we treat them, diagnose and treat them, they'll go from oliguric to now the diuretic phase. And then after the diuretic phase, they survive that, they go into recovery. You follow? Okay, so the phases isn't like, like life wherein you go from childhood to adulthood. You have to survive. Actually, it's the same, right? Because if you don't survive adulthood, will you make it to the older adult? Oh, of course not. Okay, so I guess it's the same. Right, so the patient in the oliguric period, we call it oliguric because the patient is not making any urine. So what did we do again with the oliguric when the patient was in fluid overload? How did we treat the patient? We did fluid restriction, right? And then we give diuretics. Okay, so therefore the interventions during the oliguric period involve depends really on the category. What led to the AKI? So we will treat the underlying cause, and then the goal is, of course, to push them toward the next phase. We want them to enter the diuretic phase. Then once they're in the diuretic phase, we don't stop there. We continue our treatment to get them to the recovery. All right. Now, how long does each phase last? We don't know. It really depends on how severe was the insult, meaning what was the underlying cause that led to the AKI. That will depend. So that will determine how long they will stay in each phase. Any questions so far? Very good. So the diuretic phase, we know they're in diuretic phase because, of course, what will happen to the urine output? It will be increased. They're literally diuresing in the diuretic phase. And then finally, recovery. Recovery will take a long time, right? So it can be 3 months to 12 months. In fact, we don't discharge the patient at the recovery period because we don't know when they will recover, right? That will take, when they enter the diuretic phase and they're stable, we really don't wait until recovery. We send them home. Okay, they're on their way out. Okay, if their their vitals, if their labs are stable, we don't wait because it takes too long, right? The kidneys don't fully recover until way later. But as soon as they're stable, they're okay for discharge. So here is the testable chart, 48-4, causes of AKI. There are 3 categories. We have pre-renal, intrarenal, and post-renal failure. Let's explain each one. It's really simple. What do you think is the commonality among these causes? What did the patient lose? Or what happened to the kidneys in all of these conditions? Volume depletion from, say, you have diarrhea or vomiting, you lost blood, you had too much diuretics or osmotic diuresis, such as in DKA. We'll discuss diabetes next week, DKA next week. So we have arrhythmias, any heart problems, heart failure, whether direct or indirect heart failure. But most of these are direct heart failure or vasodilation. So what do they all have in common? What happened to blood volume here? What happened to blood pressure? Decrease. So all of these have a drop in blood pressure and or blood volume, meaning what happened to blood flow to the kidneys? It dropped. Okay, so various causes, right? So here in the vasodilation, all of these conditions, I know we haven't discussed them yet, but all of them cause a drop in blood pressure. So anaphylaxis, taking antihypertensives, or sepsis patients all have low blood pressure. Same thing for these cardiac problems. A cardiac output dropped here because there is heart failure. And in the first group, volume depletion, of course, we lost blood volume, and therefore what happened to blood pressure? Also dropped. So cardiac output is low in all of these conditions. So that's why they call it pre-renal. Okay, so a result of low kidney perfusion because there is low blood pressure caused by various causes. Any question on pre-renal? So if it's pre-renal, what do you think is the treatment for this kind of AKI?
I didn't see weight loss, and then the patient will be harder, and then
You said weight loss?
yeah.
Weight loss, there's different types of weight loss, meaning did you lose weight because you lost body mass or did you lose fluids?
I'm talking about
Fluid, yeah, fluid loss. Of course, if let's say, look at the first group, right? So that is volume depletion, correct? You lost blood, you diarrhea, vomiting, or can you put diabetes insipidus here?
yes.
Yes, diabetes insipidus is not mentioned, but it's understandable, right? The patient lost fluids. So yeah, so if you lost weight, that doesn't necessarily lead to AKI. It's because you lost too much fluid, which is manifested by weight loss. Okay, but weight loss itself, not really. Okay, it's rather a manifestation of those conditions, right? Any other question? All right, so back to my question. How do you treat the AKI if these are the causes? Do you treat the cause? Yes, you treat the cause. All right, and then of course, the patient is still in AKI, so can pre-renal AKI patients benefit from fluids? Yes, except which ones will be harmed by fluids? These patients in heart failure. So this would be an exception. MI, heart failure, cardiogenic shock, arrhythmias, they won't benefit from fluids. But what about the other two? Yes, these people here, vasodilation or volume depletion, they'll benefit from fluids. So to answer interventions for AKI really depends what caused the AKI. So in pre-renal, you know there are 3 subcategories here. So all will benefit from fluids except the heart failure patients. All right? Because if we give them fluids, of course, that will worsen the cardiac workload. Okay, let's go to the next category. Intrarenal. So what can cause intrarenal AKI? What happened to the kidneys in all of these conditions? Here. Yeah, damage to the kidneys because of transfusion reaction, hemolytic anemia. No, red blood cells clog the nephrons. Or here again, another hemolytic problem. Rhabdo. Have you heard of cases wherein, I've fallen and I can't get up? Okay, so those patients who've been in that condition for more than several hours, they go into rhabdomyolysis, meaning muscle damage. Okay, muscle damage, and then myoglobin are huge molecules. Okay, these are huge ass molecules, and they will damage the kidneys. Okay, they will clog the nephrons, right, resulting in low kidney perfusion. Nephrotoxic agents, you have poisons in your body, okay, heavy metals, or IV contrast agents. Okay, we use this a lot for several tests, CAT scans, other radiology studies. Okay, so iodinated contrast agents are pretty harmful to the kidneys. So therefore, what do we do before sending the patients for these tests? What do we assess? Kidney function first. We have to make sure there's adequate kidney function. And of course, after administration, we have to give fluids to flush these substances out. Okay. And finally, infectious agents. We'll discuss pyelonephritis later in the semester, and glomerulonephritis. Since these are more pediatric problems, I'll leave that for your pediatric class. Okay. So any question on intrarenal? All right, let's go to the last. Postrenal kidney injury. So this is caused not by decreased perfusion. It's not caused by damage to the kidney tissue. This is caused by obstruction of urine flow, meaning the kidneys were fine. They were able to make urine. They were able to eliminate waste products. However, the urine couldn't come out, meaning they came out of the kidneys, but then somewhere in the urinary tract, there was obstruction. So let's say it could be stones in the ureters, or stones lower in the bladder maybe, or in the kidneys, or even in the urethra, right? So it could be a prostate issue, enlarged prostate, or could be a tumor or 2 tumors, they obstructing any structure, preventing urine from coming out. As a result, instead of urine coming out of the body, the urine went back into the kidneys and flooded it. Now that can cause acute kidney damage, acute kidney injury. So to summarize, there are 3 causes, 3 groups of causes for AKI. We have pre-renal, which is decreased blood flow to the kidneys. This could also be caused by, what if I have a stricture, a stenosis of 1 or more renal arteries? Okay, that could be another cause that will decrease blood flow, right, to the kidneys. Okay, or intrarenal, something damaged, either infection or some drug or substance that damaged the kidneys. And then finally, something obstructed urine flow. So those are the three categories of AKI. So therefore, is it easy or hard to sustain AKI? It's hard. Is it hard to get dehydrated? Is it hard to get a heart attack? No, so many things can lead to AKI. Most of them pre-renal though. You want to know how I can inflict AKI on everybody here? I can do that. Or the school can do that. All right? So it's easy actually. So most of our patients, let's say, well, you can't appreciate it yet, but let's say you'll understand more as we go through other problems, okay? Because this one did not really list all the causes. This is not an exhaustive list. Let's say here, because you see osmotic diuresis, but osmotic diuresis results from hyperglycemia. Most of our diabetics, are they all compliant with their, can they go really hyperglycemic? When they do that, or not compliant with meds or their diet, they can go into osmotic diuresis and then easily go into AKI. So now they'll have two problems when they're admitted. Sugar is really high, and then they check the kidneys. I'll bet my salary they have AKI. Does that make sense? Okay, so it's easy really to sustain AKI. Let's say someone who stopped eating. So are they just dehydrated? They come in, will the diagnosis simply be dehydration? No, it will be AKI. Understand? Understand how dehydration will get to AKI? So here, so that isn't that low blood pressure? Right, when you're dehydrated? Yes, so that decreases blood flow to the kidneys. Of course, the patient will go into AKI. So it's really easy. So you'll find this diagnosis in so many patients. Okay, they come in with another thing, plus, just an added bonus. Oh, by the way, you also have AKI, right? So I have good news and bad news. We kind of like that. All right, manifestations. So remember those 4 kidney functions we mentioned earlier? Are they still there? Regulation of fluid and electrolytes, regulation of blood pressure, elimination of waste. Are they still there? No. So therefore, those will be the manifestations. Okay. So look, this is a summary for the 3 different categories of AKI. So causes, pre-renal hypoperfusion, low blood flow to the kidneys. This one, damage to the kidneys. This one, obstruction of renal flow. All of them have increased urine creatinine. All of them have decreased urine output. You agree? Okay. Sodium levels, this will vary depending really on the cause. Okay, what caused the AKI? For instance, in pre-renal, of course, it will be low because the patient lost fluids or had heart failure. Okay. And then the sediment here, it can also be varied, but they all will be high sediment. Osmolarity, well, depends. Okay, depends on the underlying cause, but it will be safe to say that it will be all increased. Okay, because what happens to urine output here in AKI? Decrease urine output. Of course, the urine specific gravity will be increased, depending really, like this one would be more low normal because this is intra. Okay. All right, let's go now to, well, you should know these values already. Prevention, just go back to the chart, 48 dash, what was that chart? 48-4. Okay. So these are the conditions that you want to prevent. So whoever are at risk for these, then that's how you prevent AKI. Not all patients with AKI will make it. Right? It's especially the older the patient, AKI can kill those patients. As far as drugs that can cause intrarenal, meaning nephrotoxic agents, here are a few examples. So aminoglycosides, they are the mycins, and amikacin, gentamicin, those are your aminoglycosides. Gentamicin, tobramycin, here, these drugs are very nephrotoxic. So we monitor drug levels closely. Have you heard of peak and trough? Okay, so we monitor peak and trough of these antibiotics, gentamicin, tobramycin, all the way to vanco. Okay, meaning the dose will be adjusted depending on kidney function or the trough level of the drug. What are troughs again? Are they the highs or the lows? Okay, the lows. All right, here are more prevention ideas, chart 48-5. I won't read it for you. So they all pertain to the conditions and one or more conditions in 48-5. For instance, if a patient is unable to pee because of a prostate issue, how do you prevent AKI on those patients? If needed, yeah, we have to catheterize. But the important thing in the first place is to assess the bladder, yeah, assess urine output. Are they making urine? Okay, is the bladder distended? Okay, so you address it soon before the patient goes into AKI. Right. For drugs, NSAIDs are and these are over the counter, correct? So NSAIDs, we'll discuss more about NSAIDs next semester under peptic ulcer, because this is one of the 3 causes of peptic ulcer disease. Management, like I said, this is really depending on the underlying cause. So you go back to 48-4, management will depend on what caused it. Okay, of course, we treat the underlying cause, but this chapter 48, doesn't discuss those causes listed in chart 48-4. They will be in other chapters. Before we go into dialysis, which is one option to treat AKI, let's finish the CKD first, or the chronic form. I won't repeat hyperkalemia. We already discussed the options earlier before the break. So it'll be the same here. So they'll discuss same drugs that were already discussed earlier under chapter 10. For nutritional therapy, this will apply to both AKI and CKD. The only difference really between AKI and CKD is the cause, the onset, and the phase. Let me explain. Causes of CKD, because CKD does not develop within a matter of hours, CKD develops over several months, several years. So therefore, if the patient suffers a non-life-threatening cause of AKI, will they develop AKI or CKD? For instance, if I'm taking NSAIDs every day, like 6 of them or 8 of them every day for a number of years, let's make it decades. So how did I damage my kidneys? Did I damage them like this?
No.
Or little bit every day? Okay, so therefore that will lead to chronic kidney disease. Okay, so that's an example. Meaning, did I destroy the kidneys like this? I destroyed it a few nephrons at a time until I killed off all my nephrons years or decades later. Then I go into CKD. So that's one difference, the onset. Another difference is the recovery. So we know there are phases in AKI, correct? What are those 3 phases? Forget the initiation. What are those phases? Oliguric, diuretic, and recovery phase. There are no phases in CKD. What CKD has are stages, meaning they can go from stage 1 all the way to stage 4. Okay, meaning it indicates the severity of the damage, right? And unlike also AKI, wherein there were phases, right? So they had oliguric, diuretic, and recovery. Because there is no cure for CKD, they are stuck in the oliguric phase forever. Nothing will change. Once you have CKD, all you can do is preserve what remaining nephrons you have. That's all you can do. Just avoid further injury. So whatever you were doing, let's say it was caused by the diabetes that you have, uncontrolled diabetes. So how do you preserve remaining kidney function? By managing your diabetes better. What if it was your blood pressure? Blood pressure so high all the time that led to nephron damage. You have CKD now. How do you prevent from going into stage 4? Let's say you're in stage 2, stage 3. How do you keep it from progressing through the stages? You manage your blood pressure and so on. Do you understand? That's the only difference between AKI and CKD. So CKD patients are stuck in the oliguric phase forever. There are stages though. There's no cure. However, can you delay the progression? Yes, you can delay the progression.
What about the patients that they have a high cholesterol, their BP is always high?
Well, we can't avoid that. They will, because imagine what's the size of your nephrons? Can you see the nephrons? They are microscopic, correct? So do nephrons have blood supply? Because nephrons are cells too, correct? So do they have blood supply? Yes. So if nephrons are microscopic, how much more the capillaries that support or supply the nephrons? Even tinier. Now subject those tiny microscopic capillaries to high blood pressure for 10, 20, 30 years. What will happen to those? They will be damaged as well. So no, doesn't spare any nephrons. Okay, so nephrons will die from chronic high blood pressure. Okay, nothing will survive that. So we'll discuss dialysis after we do CKD. Although here it says oliguric phase may last 10 to 14 days, like I said at the start, we really don't know how long. Some people will recover sooner. So let's say the dehydration was quick, right? So I just had the diarrhea today, and then I was admitted to the hospital. Of course, I went into oliguric phase, right? But then I was aggressively treated. They stopped my diarrhea. I got fluids replacement right away. So will I enter the diuretic phase sooner? Yes, it may not last even days. Okay, it could be a matter of hours. Really depends on when did we catch it and how old are these patients. Okay, so that will determine how fast they recover. So as early as now, is AKI and CKD a fluid and electrolyte problem? Definitely, right? Definitely, because it's number one job. So therefore, if there is a decrease in its function, of course we have fluid and electrolyte problems. So how did we assess again the patient's fluid status from last week? What were the items we assessed? Did we assess urine output? Did we assess weight? Did we assess the veins? Did we assess lung sounds? Did we assess BUN creatinine? Did we assess hemoglobin hematocrit? Okay, did we assess the patient's vital signs? Heart rate. Okay, so what do you assess in these patients to see their fluid status? Exactly the same we did last week, right? So there's no difference. And why is hyperkalemia a problem here? Okay, and which eliminates 80% of our body's potassium? Very good. Okay, so this is a very common problem. So is the patient in AKI only dealing with AKI? What are they dealing with? Hyperkalemia as well. All right, so metabolic rate, of course, the patient is in injury, so one or more organs are injured, so therefore the patient's metabolic rate will increase or decrease. Increase. Any sick patient will have a high metabolic rate, meaning cellular metabolism is increased. So they require higher calories intake, which they cannot provide because they are sick. Okay, there's mental status changes because of the increased waste products. So what's their pH here? Are they in alkalosis or acidosis? They are in severe acidosis here, moderate to severe acidosis. So that's another problem. Infection, because these patients will, because how do we measure hourly urine output? Because that's our number one indicator, right? Besides the weight, we need to monitor urine output. So how do we measure whether they're making 0.5 mLs per kilogram per hour or not? How do you know? Do we wait until they pee? Do we tell them, hey, use the urinal, okay? Whenever you pee, use the urinal. But we need to monitor it every hour. Do we pee every hour? Can you pee every hour? If I pay you $500, go pee. You try your darndest, right? Squeeze whatever is in that bladder. So of course these patients can't do that. So what's the only way we can measure hourly urine output? A Foley. We need to put in a Foley. It's justified here. There's a reason for the Foley, which is what? To monitor hourly urine output. There's no other way to measure it, okay, without a Foley. So of course, what will happen if it involves a catheter? We have a catheter-associated urinary tract infection to deal with. That can cause another problem, an infection. And what was one of the causes again of prerenal AKI under vasodilation? There was sepsis there, correct? Yeah, so if the UTI goes untreated, they could go septic because of the AKI. I mean the UTI. Here providing skincare because what does the body do when the kidneys don't eliminate the waste products? Where will we eliminate the waste products? Through the skin. So there will be some skin issues here. And is this life-threatening potentially? Yes, so you provide support to the patient and the family. Patients probably here, if it's severe, really, metabolic acidosis severe, they're unconscious. So we're dealing with the family. Family, are they easy to deal with than the patient? Most of the time, no, right? Especially we're dealing with a parent, a child, okay? So nothing personal though, okay? Why are they behaving like that? What is that a manifestation of? Loss of control, correct? So the diagnosis for that is powerlessness. So manifestations of powerlessness are anger, agitation, okay? So they'll shout at you because do they have control over the situation? None whatsoever. So what can they control? Yeah, that's the only way. The only thing they know is, I know I can shout at you. Okay, I can't help my mom or my dad, but I can shout at Sarah. What are you doing? Why are you on your phone? My brakes are somebody's covering for me. Anyway, so here's CKD. The development again, unlike AKI, when it developed within hours, this one develops over months, over years. Did we see this coming? We should have, right? But do we observe it though every day? We don't, because the development was so subtle. And the symptoms, did they come like overnight? Like they were fine yesterday and then no, the symptoms were very subtle. We hardly noticed them. Right? So the end result of CKD, especially if the patient does not treat the underlying cause that leads to it, and here, untreated CKD can result in ESKD. ESKD, old name is ESRD. So don't be surprised whatever terms the doctor or nephrologist uses, they really mean the same thing. ESKD, ESRD, it's just a matter of which term is more updated. So the most updated term is ESKD. Just like AKI used to be called acute renal failure, okay, not kidney injury. When we get to ESKD, of course, the patient has zero kidney function, meaning the GFR is less than 30 mLs per hour. So therefore, they need dialysis, or what we call renal replacement therapy, RRT. So these are the problems with ESKD or CKD patients. These are related to the kidney function, which is now gone. So table 48-1. So I mentioned there are stages, right? There are no phases, there are just stages. Stages are determined by GFR. So stage 1, still okay, you're still over 90. Stage 2, 60 to 89. Stage 3, 30 to 59. Stage 4, 15 to 29. Stage 5, which is ESKD, less than 15. Manifestations. To make it easy, CKD patients are in which stage of which phase of AKI? Permanently? Which phase? The oliguric phase, forever. They'll never snap out of it. They'll be in that oliguric phase forever. So what is their fluid status? Are they in normal fluid volume, overload, or deficit? They are permanently in fluid overload forever. Let me correct when I said there's no cure. There is, if you can get new kidney. Okay. Well, there's really no such thing as a new kidney. A recycled kidney is the better term, correct? Because you get it from somebody else. So there's no brand new kidney. It's just a recycled from somebody else. So as of now, we haven't done any successful interspecies kidney yet. We've done heart, right? Somebody survived. You've seen the news. No, they got successfully transplanted a pig's kidney to a human. And the guy lived for, I don't know, 30 days, I think. Yeah, 30 days, but that's a promising, we've never done that before. Okay, so we'll do better next time. Okay, so maybe we can do that. Yeah, farm an entire, millions of pigs for organ, for heart transplant. Yeah, wouldn't that change the world? Yeah, so your grandfather or your parents who need transplant, now they can get one from pigs. Yeah, these are not regular pigs though, so don't go out going to the farm and getting one. Okay, these are genetically bred pigs. Okay, they're specially bred for that purpose. It's not a regular, swine. You go out hunting and let's get a pig. Getting a heart. Don't go hunting for your heart. Right, medical management. Because the patient is in fluid overload, so therefore, what is their BU and creatinine? High. What's their blood pressure? High. What potassium level? High. All right. What's their waist? Specific gravity of the urine? High. Okay. All right. So you know already, fluid overload forever. Right? Fluid overload forever. So these are our management overall. We want to keep the blood pressure between that. It's easier said than done. It's not really easy to maintain blood pressure. So you can just imagine the number of medications these patients will have. Have you ever been assigned to a dialysis patient in clinical? Who has here? I see you nodding. So you've seen, how many medications have you seen on the MAR for these patients? Too many to write, yeah? Okay, there's so many drugs they have to be on to keep them alive. So, because they're not taking one medication for blood pressure. It's multiple, usually 3 or 4 or even more, right? They'll be on diuretics, okay? Not to mention their diet. Their diet is strictly limited, restricted to so many potassium, so much sodium, so much protein. Because where did BUN creatinine again come from? Where did BUN come from? from nitrogen, from nitrogenous waste, which is from protein, right? So we have to limit these things, right? So it's not easy living with CKD or with ESKD, right? So some patients with CKD, some of them, listen and then comply, right? But most do not. So these are the problems. Now, in addition to systemic diseases such as these, patients will also have, of course, heart failure as a result. And then they'll have pulmonary problems because the fluid overload, okay, will affect the lungs, right? So there could be plus, will there be anemia here now? Yes, there's anemia here now because we're not talking overnight. This is for a long time. So for a long time, their kidneys have not been able to secrete what hormone? Erythropoietin. So we're dealing with anemia here. Will they require blood transfusions? Yes. Okay. So it's a complicated condition. Okay. So they'll at risk for fat in their arteries, hypertension, heart failure. Most of them, though, years ago during my time, the number one cause of ESKD, people going on to dialysis, was hypertension. Now, diabetes is number one. Half of the patients that are on dialysis are diabetic. Half, right? So whenever you have, and dialysis is actually a very nice, stable career. You want to go into dialysis nursing, nice pay, nice benefits, 8 to 5, right? Unless, of course, you go into the hospital, then on hospital, there'll be shifts, okay? But you can pick up shift if you don't want that, stay at the clinic, right? Nice, stable job. Same thing you do every day. Stick a needle, take out the needle, stick a needle, take out the needle, stick a needle, take out the needle, right? Yeah, the same thing, right? You become an expert. Oh, Arif was a dialysis nurse for most of his career before he went into nurse practitioner. He was a dialysis nurse. You can ask him, how many decades he did that. It's a nice stable job. And you become a master at these things. Okay, let's go now to hemodialysis. There are two ways to do renal replacement therapy. So the term is renal replacement therapy, RRT. Most common type is hemodialysis. So what is dialysis? So it can be hemo, could be continuous renal replacement therapy, or peritoneal dialysis. These are all methods of dialysis. HD is the same as CRRT. The only difference is the rate of fluid removal or the duration of the dialysis. HD can be done up to 4 hours, or it could be shorter. If the patient doesn't tolerate it, you can do 1 hour or less than an hour, maximum 4 hours. CRRT, however, can be up to 24 hours. CRRT, or continuous renal replacement therapy, is only indicated for really unstable patients. We're talking those critical patients who have very unstable blood pressure in the ICU. You will never see CRRT outside the ICU. Are we clear? It's only seen in these, it's only done in those patients because they're the ones that cannot tolerate regular hemodialysis, because we have to remove the fluid slowly, little bits at a time, and that takes up to 24 hours, right? PD is the most convenient, well, I shouldn't say that. PD is the only one that can be done outside a healthcare facility. But you know what? Even that I can't say anymore because they can do HD at home now. Patients can do it themselves. Okay? They have smaller machines now. However, they have to do it every day. If they do home dialysis, because they can't remove so much fluid, so they have to do it daily. Okay, there are home dialysis machines now. All right, let's talk about each one. Let's start with HD. HD is using a machine. So you have a dialyzer here. So this is the setup. So it's a big ass machine. Okay, it's like a ATM machine, big. It will clean the patient's blood. There's a dialyzer here. It's like a filter. Okay, so your blood will flow through here, clean. It's cleaned by osmosis and ultrafiltration, and then the blood returns to the body. To use this type of hemodialysis, you need an IV access. You have to be able to remove blood from your body, put it into the machine, and then return it to your body. So our responsibilities here, I won't discuss the hemodialysis procedure because you're not expected to perform hemodialysis after graduation. Let me show you again the NCLEX test plan. So on the NCLEX test plan, if we search for dialysis, what does it say? Perform and manage care of a patient receiving peritoneal dialysis. So no hemodialysis mentioned here. Okay, so peritoneal, yes, but no hemodialysis. Okay, so you're not expected to. So here. However, if someone is on hemodialysis, are you doing the dialysis or simply managing the care of a patient receiving hemodialysis? Simply managing the care. So it doesn't say perform hemodialysis, does it? However, did it say perform peritoneal dialysis? Yes, it did. Okay. Right here, see? You're expected to perform peritoneal, but did it say perform hemo? No. So therefore, does it make sense? Do we have, I have to come here and demonstrate hemodialysis? Well, I don't know how to do that either. So no performance of a hemodialysis, but are we expected to perform peritoneal? Yes, we are. All right. So let's go. Okay, go back here. So we need an IV access. Now, so we'll skip through the dialyzers, okay? So let's go to the vascular access. So we need vascular access. It has to be big. So earlier today, we already did the central lines, yeah? And what's the fifth central line? Hemodialysis catheters. So hemodialysis catheters can be tunneled or non-tunneled, okay? So same exact spots, all right? So same, it could be the jugular, could be the subclavian, or it could be the femoral, okay? So same, it's a central line. However, they're bigger catheters though. They're not smaller compared to central lines. So central lines used for medication administration or any other purpose are smaller compared to a dialysis catheter. So dialysis catheters are bigger, whether they're tunneled or non-tunneled, they're way bigger than regular central lines. So here are just like what we said earlier. So we've got the jugular, we have the subclavian, or we can have the femoral. Because they're central lines, where is the tip? In the superior vena cava. Okay. So there are ports, two ports obviously. Blue is obviously the return port. Red will be your draw port, meaning the red port is where you attach it. This will draw blood from your body, put it through the dialyzer, and return it back to your body through the blue port. So while it's outside, it will get cleaned again and then return to the body. Another access would be a AV fistula. So AV fistula is surgically created by a vascular surgeon. So what they'll do is map it first. They'll do an ultrasound of your veins in either arm, and they'll look for two vessels, an artery and a vein. So they'll look which is the prettiest artery and vein that they can see. When they find those prettiest, they will surgically connect them, meaning they'll create one big blood vessel out of an artery and a vein. So they'll connect them surgically. What happens when you expose a vein to the same pressures as an artery? Are veins built the same way as arteries? Which ones are tougher? Arteries, because they have higher blood pressure. There is no blood pressure on the vein, right? Because veins only return blood through muscle contraction, correct? There is no pressure to speak of. So when you expose a vein to the same pressures as an artery, which is what happens here, what will happen to that vein? Will it stretch? Will it dilate? So this thing, this fistula, fistula, by the way, means an abnormal connection. Because are veins and arteries normally connected? No. So therefore, if you create a fistula, is this a normal connection? No, you've created an abnormal connection. Okay, so that's what a fistula means. So you created a arteriovenous fistula. So this thing will grow. So after a few weeks, few months, few years, it will grow. When it grows big enough, now do we have a big blood vessel? Can we stick it repeatedly? Yes, because we need 2 needles right here. We need 2 needles because we want to draw blood out and then return blood back. So 2 needles. So can we do that with a tiny vessel? No, we need a big blood vessel to do that. So we need to, so these are your options. Okay. So obviously a fistula, which one would be the longest? Or there's a third one. A third one is a graft. A graft is a silicone rubber, and then they'll just put it into a vein and a graft. So it's an artificial vessel. It's not really your own vessel. Obviously, because it's artificial, do these things last long? Not really. They're not really gonna last long. I mean, it's gonna get damaged eventually. So the preferred would be a fistula. Now, not all patients are candidates for fistulas. Sometimes their fistula goes bad. And so we have no choice but to put this dangerous portal of entry. All right. So of course, do you like central lines? Again, central lines are dangerous. Okay, we don't want central lines, but if the patient needs it, then what can we do? All right. So which is the ideal again? The AVF. This one is the ideal. Okay, we'd like to have all patients should have an AV fistula. They can't have one for whatever reason, then these are your remaining options. Either a graft or a central line, a dialysis catheter. Any question? All right, so questions on the test will be, what are your responsibilities over these patients receiving dialysis? Okay, just like on the NCLEX, it said, manage the care of patients receiving hemodialysis. Okay, first of all, the AVF, if you have an AVF, do not do anything on that arm. Let's say they have an AVF on the left arm. Don't do anything to that. You can't draw blood from that arm. No blood pressure readings. Don't even yank the patient's arm on that side. Yeah, treat it like royalty. Okay. Hey, there's your royal armness. Okay, so that arm is special. Okay, the patient needs that arm. That hemodialysis fistula, we need that arm. So don't do anything. Okay, so cradle it. You okay? Talk to the arm. You okay? Anyone hurting you? Tell me, okay? Right. I'll be back later. Okay. Take care. And you always assess 2 things on the fistula or graft. You always look for a bruit and a thrill. What is a bruit and a thrill? Right here, this bruit and a thrill. Bruit is a sound, so you listen for a bruit. This is a large blood vessel, so will you hear something when blood flows through it? Yes, so you will listen with a stethoscope. Put a stethoscope over the fistula and you will hear. Okay, that's a bruit sound. It kind of like this. Like that sound, okay? When you rub your hair like this. So that's a bruit. A thrill is, of course, this will vibrate. It's a huge blood vessel, okay? It's huge. And then blood flows through it. Of course, you will feel the blood as it flows through it. So we call that a thrill. So what do you assess again? Bruit and a thrill. If you can't feel a thrill or listen to a bruit, what should you do? Notify the physician, okay? Because they need to assess this thing. Why is it not giving a bruit or a thrill? Meaning, is there blood flowing through it? Maybe not. Okay, so maybe it's clotted. Okay, so they need to do something. Because remember, the patient's life depends on these venous access devices. This is their kidney. Okay, I mean the machine, but this is their access for the artificial kidney. So you need to take care of it and report whenever you suspect anything out of the ordinary. So here, failure of the permanent venous access, which is the fistula or graft. Patient is in trouble. So therefore, if they fail, what's the only other option? To dialyze the patient. A catheter. We need a central line, a dialysis catheter. So again, do not, you put a limb alert, signs everywhere. Okay, no lab draws, no IVs, no blood pressures. Any question? All right, complications. So since HD is basically replacing their kidney, this is the only way these patients will live normal lives. Okay. Without dialysis, they'll die soon after. So complications can be, let's say if somebody decides, I don't want dialysis today. I have a party to go to, my friend's birthday. Okay, we're going to be drinking. I have no time for hemodialysis. So that's what they do. Okay, party, right? And they can do that. But what will happen the next day? What is their fluid status? Fluid overload, severely uremic. Okay, so they'll pay for it. So they'll be in heart failure and, complications of fluid overload. So they'll come in, and then you'll save their lives. Okay, so you give them diuretics, put them on dialysis. Okay, can they do that? This is America. Okay, they can do whatever they want. All right. So our job is just to educate and save them whenever they do that. Right? Okay, but we don't do hemodialysis every day though. They'll go into dialysis center 3 days a week. So it could be either Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. So there are days in between where they don't receive any dialysis. So that would be 2 days a week, right? 2 consecutive days that they won't have it. 1 day, but then there will be a 2-day no non-dialysis days. Remember? Because if it's TTHS, then there's no dialysis for Sunday and Monday. Same thing for Monday, Wednesday, Friday. They don't have Saturday, Sunday. Okay. So it's really crucial. During those days, these could happen. They could have shortness of breath. They could have, during dialysis, especially after dialysis, they will go into hypotension because we're moving up to 4 liters of fluid. In a session, single session, we can remove up to 4 liters. That's a lot, right? I mean, how do you lose 4 liters in a day? A matter of 4 hours, right? You can't do that without dialysis. So it's only done here. So of course, that's rapid fluid removal. Can they go into fluid deficit? Yes, that's possible. Cramping, because you're not only losing fluid, you're also losing electrolytes. Again, these are all a matter of hours. Painful muscle cramping is the result. And then there's also exsanguination, meaning the site, you move and then the dialysis catheter came out. Okay, and then there's infiltration now. Okay, so it's messy. Arrhythmias, again, due to electrolyte imbalances, air embolism related to the site, or chest pain, especially if they have anemia or heart disease. And there's also disequilibrium. This is again related to fluid shifting because of course you're moving fluid. So will there be osmotic imbalances? Yes, there'll be some fluid shifting. Okay. And like I said, they could end up losing so much fluid that they'll go into AKI. Now you may wonder, how can a CKD or ESKD patient develop AKI? They can't. Okay, so these patients, you can't say, oh, they already had CKD. There's no way they can go into AKI. Guess what? They can. Okay, because can they still suffer intra, or post-renal? Absolutely. Now, as far as because they are in an oliguric state forever, correct? So are they going to have no urine output? Possible. They could be anuric or oliguric, but not all patients are anuric. Okay, some of them still pee. Okay, some of them even pee regularly. Okay, really, it's strange. It's weird. But most patients are oliguric, so not much urine coming out. So I mentioned earlier, these patients are in fluid overload. So what do we do fluid wise? Water intake. Can they drink whatever they want? Fluid restriction. So it's very important to do INO because again, the basis of fluid restriction is what? Yesterday's urine output plus insensible fluid loss. Again, I repeat, yesterday's urine output plus insensible fluid loss. Okay. So is urine output recording very important?
Yeah.
It's crucial. Nephrologists will snap at you. Okay, they'll say nasty things to you. They'll call your supervisor, your manager. You'll call your grandmother. Okay, so that's how much they hate when nurses do not record accurate INO, okay, on dialysis patients. Because really, can you blame them? No, because the therapy of this patient depends on accurate urine output recording. If you miss the urine output, this could harm the patient. Do you understand? Okay, so again, nothing personal, okay? They just want you to do your job, especially intake and output. Fluid restriction, again, we already discussed. Do we weigh these patients? How often? Daily, every day. So daily weights, especially before and after hemodialysis. I already mentioned the fluid restriction. Now we have diet restriction. So what do we restrict again in the diet? Everything, protein, everything that comes into their body, protein, electrolytes, how much electrolytes. So the dietitian will follow whatever the doctor prescribes, especially potassium. Are we clear? Okay. This one, the psychosocial really doesn't make a difference from one chapter to the next. I mean, how do you think these patients with chronic illnesses like this feel or behave? I mean, imagine yourself in this scenario. You're dependent on a machine for the rest of your life. You can't travel easily because when you travel, that means you can't suspend your dialysis. You need dialysis to wherever you want to travel. Say you're going to Boston for a week. Can you go without dialysis for a week? No, you need dialysis 3 times. So can you just go overnight? No, can I like right now? Oh, I'm leaving tonight. Okay. Have a vacation. No, the vacation has to be planned way in advance because the doctor has to contact a dialysis center there, contact a nephrologist to give orders because there's no walk-in dialysis center. Can't go here, hey, I need dialysis. You have an opening today? Can't do that. You need a doctor, and no doctor will give you dialysis out of the blue. You have to go to a hospital. That's an option. Hey, you go travel, but you're gonna have to check yourself into an ER. And you know what they'll do? They will just won't do dialysis. They'll admit you. So what happens to your vacation now? See what I mean?
What about those with the portable machine?
They can do that, but again, you have to do it every day. I mean, that's an option. But I mean, when you travel, there's always a party, right? Yeah, so probably not adequate for what you're planning to do. I like how you think though. You're trying to, All right, so these are of course, reactions, depression, anger, social isolation. Okay, I have 3 minutes left. This is your summary for HD. So here's the home hemodialysis. I won't discuss it. I won't test it. Let's go to the peritoneal. Okay, I can do this in 3 minutes. So this one uses the patient's own peritoneal membrane as the semi-permeable membrane. First of all, of course, these are the advantages, disadvantages. So the doctor and the patient will talk about this. Okay, is this really an option for you? So here are the advantages. You don't have to be stuck to a dialysis center or a machine because you can do this yourself at home. There's no machine involved. So you can travel, you can do whatever you want. Okay, there's no diet restriction here also because you actually lose potassium, you actually lose protein during the procedure. So no restriction here, no fluid restriction, none whatsoever. This is the disadvantage. You have to do this 7 days a week, but you'll have to do 4 to 5 times a day. 7 days a week, 4 to 5 times a day. So these are the indications. You qualify for peritoneal dialysis if you meet these conditions. Contraindications, you have these GI problems, then you can't have this option. Let's talk about the procedure. To accomplish this, the doctor has to implant a catheter. So here's the catheter right there. The doctor will surgically implant it. So catheter's in your peritoneum, and then this is the catheter protruding out. You just put a small dressing here, and voila, you're ready. Okay, no, no long wait. So this is put in a few hours, ready to use. Okay. So that's the catheter inserting. It's inserted by the doctor. Now let's go to the procedure. One round of peritoneal dialysis is called an exchange. There are 3 phases in an exchange. An exchange will last about 2 to 3 hours. An exchange has 3 phases. One is the dwell time. Second is the, no, sorry. First phase is the, first step is the inflow. Second step is the dwell time. And then the third will be outflow. Let me describe it. Where's the picture? Is it above? Oh, right here. Okay, so inflow, you hang this huge bag. This bag is called a dialysate. So this will be shipped to your house. They're about 2 or 3 liters, depending on the doctor's order. Let's say it's 2 liters. That's the smallest bag. You connect it with a tubing, okay, aseptically. First you have to do is wash your hands and wear gloves. Wipe alcohol with a catheter. You connect it, infuse the 2 liters into your abdomen. That takes about 10 minutes. You disconnect it, you go whatever you want. You can go to Disney, you can go shopping, to the bank. Carry that 2 liters in your belly. It's not in your stomach, it's in your peritoneal, okay? It's in your abdominal cavity. After 2 hours, you go back, you attach the bag, this time to drain it. You attach it, let it drain. You move around, move from side to side, walk around. Get rid of that fluid. So of course you expect more or less fluid to come out. If 2 liters went in, how much should come out? At least 2 liters, but it should be more because what is it removing? Extra fluid, extra waste products, extra electrolytes. Okay, that's your dialysis. After that, start it again because you have to do 5 exchanges a day. So if it lasts 3 hours, you have 24 hours. You see the scenario here? You have to keep doing it. The last dialysis exchange will be overnight. You put the fluid in, you go to sleep, drain it in the morning. That's the last exchange. If this kind of life suits you, there you go. It will work. Okay, let's say I'm in Disney World. Okay, so I'm waiting for a ride. I have an IV pole, or let's say I don't do IV pole. I go to the bathroom. Okay, I connect this somewhere, a hook. Okay, I put it in. So I'm carrying the 2 liters. I go back in line. I'm not gonna go in line because I have fast pass. I give them a medical record, medical card. Hey, fast pass. All right, so I skip the line. I go on the ride. so many rides I go to. 2 hours later, okay, it's time to drain. I go back to the bathroom. I drain it. It'll work. You agree? Yeah, this will work. Okay, same thing here. If I go to school, I have this, I go to the bathroom. I'll connect it, sit in class for 2 hours, okay, or take an exam for 2 hours, and then go back to the bathroom, drain it. Yeah? Okay, we'll continue with the complications next week.